Now that's about the artifacts due to the jewelry and then the foreign objects. Now let's focus on the artifacts which are due to the tomographic technique or the patient positioning in itself. This is an artifact which is caused by a motion, right? When we are acquiring or acquisition of the radiograph, if the patient does a sudden movement, due to various reasons, it can just be a hiccup, you tend to see this kind of an artifact. It's not continuous. When you compare, always when you're seeing a panoramic radiograph, you always have to compare it on the contralateral side, whether there is symmetry or asymmetry. If there is any kind of asymmetry, you have to go in detail of that particular asymmetry and then try to eliminate the different causes of that particular asymmetry, right? Now when you look at this is not continuous. This side it's continuous, this side it's not continuous, but clinically the patient is very bilaterally symmetrical. Now this you have to attribute it to, and also there's so much of distortion on the focus and then the clarity of the structures involved there because of the motion. Now tell me, what kind of artifact can you see in this? Anybody? You mean to say there's an enlargement on this side? Where exactly? Where exactly is the enlargement? Yes, there is some amount of enlargement on this radiograph, but which part of the radiograph is enlarged? Where? Angle of the mandible, fantastic. Yes, this is where the enlargement occurs. This is basically because when you compare the width of the body of the ramus here and here, there's an obvious thickness or enlargement on the right side, right? This is not exactly a pathology. This is not a variation also. This is an artifact caused because the patient positioning. This is because of the axial rotation of the patient. The patient is not looking straight, the patient is slightly tilted towards one side on the axial plane. When we see from the patient from above, the patient is not positioned in the regular plane, but it's slightly rotated. This artifact is due to the axial rotation of the patient during the acquisition of the panoramic radiographs. We had a discussion in GDP regarding this. I think Dr. Nadeem, he had put a OPG regarding that. There's a thickness of the widening of the body of the ramus of the mandible. Now when you see this OPG, what do you see? There is so much of space created in between the central incisors and the lateral incisors up to the canine. You can see it looks like there is a diastema in the central and lateral incisors, right? The diastema is not generated, it is not clinically present, but then this is generated due to the positioning of the patient right anterior to the focal trough. This is the area where your teeth should be when you are acquiring a radiograph. But then if you keep your teeth in the front of the focal trough, you get this spacing in the centrals and the laterals, and then it just widens up, okay? And then similarly, if the position is placed anterior to the focal trough, this is what happens. The teeth begin to crowd up. When the teeth begin to crowd up, the clarity is lost, the region of interest is lost, and then also the interpretation of the radiograph can be misinterpreted. Again, if you look at this OPG, when you look at this OPG, it looks like a square jaw syndrome. There's something called as a square jaw syndrome, wherein people have literal square jaws, okay? But then this is not a patient of square jaw syndrome. Basically because when you see the occlusion, it has an upward pattern, right? You can see there's an upward V. This is attributed to the lift of the patient's chin while acquisition of the radiograph. When the patient lifts his chin, instead of keeping it straight or flat parallel to the ground, this artifact appears on the radiograph. Now when you lift the chin, that's what happens. Now if you put the chin down, this is what happens. You have a downward V. That was the upward V, this is the downward V, right? And then again there's a lot of loss of focus in the anterior region of the teeth. You'll not be able to decipher, and then you'll not be able to see anything. And also when you put the chin, when the patient puts the chin further down, you can actually see the cervical vertebra far better than the regular OPG. You can appreciate the C1, C2, C3, C4 on either aspects. This patient does not have hyoid bone. Okay, now there's nothing more deceptive about the obvious fact. When we say there's nothing more deceptive, what exactly are we talking about? When we say we have to eliminate the impossible and whatever remains, however improbable, must be the truth. So says Sherlock Holmes. Okay? Now to conclude, not too much of interpretation is not really required. The basic idea of the normal anatomy of the bony structures as well as the soft tissue structures is paramount in identifying any pathology. But too much of interpretation can also lead to misinterpretation and will lead to misdiagnosis. Okay, that's about the first part of my odyssey. I think the second part I'll start in a moment. Just 5 minutes break of the anatomic variations. Okay, this is more like interactive session. In this, I think you guys are participating more than me talking on this particular presentation, right? Now, the curiosity is the fuel of discovery, inquiry, and learning. With this in mind, let's progress. Now, what exactly do you see? I have a patient who's a 56-year-old female who comes to me with difficulty in opening of the mouth. Okay? Just difficulty in the opening of the mouth. What exactly do you see? You saw the normal anatomic features, right? Now you know the mandible, you know the coronoid, you know the condyle, you know the body of the mandible, you know the angle of the mandible, you know the maxilla, you know the sinus, you know everything. Now this patient comes to us with pain in the maxilla with limited mouth opening. What can it be? TMJ? Okay, I think that's the first thing which pops up into the mind. Okay, any pain attributed to TMD. That's not how it is. Okay, let me take you through. Okay, we're starting with the maxilla, right? This is an edentulous patient, 56-year-old. This is the maxilla. This is a maxillary sinus. Okay, and also she complains of stuffiness of the face on the right side. Okay, this is what we see. The area marked in blue is the anterior nasal spine. Okay, this patient has a curved hyoid bone on either aspect, and then there's a big maxillary septa into the maxillary sinus of the right side. This is the cause of the stuffiness of the face for the patient. And also there's a bifid canal on the left side. One canal, and then there's a branch which is coming right in the front anteriorly there. Plus, if you see the lateral pterygoid plates, these are far elongated, and this is the attribution for the limited mouth opening. Okay, the next slide. 27-year-old female comes to us with the feeling of something stuck in the throat or something constantly poking in her throat. You saw the normal OPGs, right? See, mind you, this is not a pathology. This is just a variation in the anatomy. Okay, when we say variation in anatomy, it can be either an anatomical variance or variation in anatomy. It's debatable. But what exactly do you see? Anybody? Okay, when you look at the palate here, just try to follow the palate, right? When you see the palate here, there's something pokey here at the angle of the mandible. Do you think this is normal? Is this seen in every radiographs? No, this is not seen in every radiographs. We are going systematically, right? We started with the anterior nasal spine. We are going systematically. This is the posterior nasal spine. Right in the middle of the palate, when you take the impressions, there is something called as fovea palatinae, posterior to that. Soft palate. Okay. Okay. 46-year-old female. What do you see? Asymptomatic. Absolutely asymptomatic, but the only thing is she's not able to open the mouth. Okay, fantastic. Hyoid bone is curved. What else? I gave you the clue. I told you the patient is not able to open the mouth. What can cause the limited mouth opening, or what can prevent the patient from opening the mouth? Okay, let me give you the answer. Okay, what exactly is this? This is the articular eminence, right? If you look at the X-ray, there's elongation of the articular eminence bilaterally. This is the X-ray, right? When you look at the region here in the TMJ, this articular eminence is almost covering up to the half of the condyle. This is not common. Because of this, this is what is limiting the patient's luxation and opening and closing the mouth. And also this patient is wearing a necklace. And as Dr. Nadeem said, she has a curved hyoid bone. Okay, 49-year-old patient. Okay, there's no control of the jaw movements. She can just lip it out and then put it back in. Subluxation. Yeah. What do you see? What do you see? There's a pattern to it. I'm going systematically. Okay, I started with antenasal spine. I went to posterior nasal spine. Then I came down. Then this again. Follow a pattern. There's a pattern. Like the interpretation of radiographs follows an organized pattern. It's a systematic process, right? What else? What do you see in this? You see multiple stuffs in this. You see multiple stuff. Okay, this is what is this? This is the external acoustic meatus. Okay, does it look normal? Does this look normal? Yes or no? No? Why? Why is it not normal? Yeah. Why? It is normal, but the only thing is it has an accessory foramen in front of the external acoustic meatus. This is not common. This is a variance. There is the presence of an additional neurovascular bundle in front of the external acoustic meatus. This can be attributed to the most possible causes of pain, swelling, metastasis of the infection into the middle ear, and also this is the hyoid, this is the styloid bone, yeah? This is the posterior nasal spine. We have accessory external acoustic meatus foramen, and also on the left side, there's flat eminence. There's no eminence. This is the reason why the patient can easily subluxate and then put it back on her own, the mandible. Okay, 43-year-old female, again with limited mouth opening, but stiffness in the right ear, pain in the right ear. She's not able to sleep on the right side of her face. This is the clinical features, okay, and this is the radiograph. And what is it that you see? The patient says, I cannot sleep on the right side of my face. It pains whenever I sleep on the right side of my face. Anything? Anybody? No? Okay. If you see clearly here, there's a soft tissue shadow here, right? This soft tissue shadow is attributed to what? The pinna of the ear. And then there's a calcification here. This is the calcification of the what? Auricular cartilage. Okay? This is also known as petrified cartilage. Because of the ossification of this cartilage, the ear becomes stiff. And whenever the patient is trying to sleep on the right side, it begins to pain. This ossification is attributed to repeated injury or repeated scratching of the ear. And then she also shows signs of initial stages of calcification of the thyroid cartilage and the carotid atheromas. Yes. Okay, 24-year-old female. You see external acoustic meatus on either aspects. Good. This is a routine investigation and a routine finding. The patient is not associated with any signs or symptoms of pain or discomfort in any parts of her face, neck, or the mandible or the jaws. When we're looking at the external acoustic meatus, we follow down. This is what? What is this? This is the styloid process. And then in this patient, incidentally, there's a variation of bifid styloid. The styloid is not single, it's bifid. There's a small styloid here, plus there's a long styloid here. Bilateral. This is not a common variation at all. Okay, moving ahead, this is a 35-year-old female. Limited mouth opening, not able to open the mouth after maybe 20 centimeters. 20 millimeters, sorry, 20 millimeters. And then because of this, even you can see the occlusal plane is flat, almost flat, right? Limited movements on the condyles. What do you see? What do you attribute it to? Limited mouth opening is not just because of the TMJ. There's something else to it. What else? What else can be attributed to limited mouth opening? If you look at the coronoids of this patient, if you follow the anatomy here, bilaterally, Do they look normal to you? They look normal to you? They're elongated, right? Because the elongation of the bilateral coronoid, when the patient tries to open the mouth, the buttress of the zygoma prevents it from coming more further ahead. This is the reason why she has limitations in the mouth opening. And incidentally, this patient had branches of coming out from either of the canals. Okay, 38-year-old male, 38-year-old male, asymptomatic, routine finding. What do we see? We saw the coronoids now. Focus on the condyles. How are the condyles? Pencil shaped, right? These pencil shaped condyles are most often seen in patients affected with osteoarthritis. Okay? And also, if you look at the nerve on the left side, this patient has trifid canal, trifid nerve. And also, if you look at the pterygoids here, both the sides, the pterygoids are elongated. And on the right side, the canal is dual. Most of these cases are under review for publications. And then again, 33-year-old male. What is it that you see? Okay, positional artifact. Okay, what else? You see the cervical vertebra on either aspects. Okay, what else? Am I going too fast or am I going too slow? Or am I not clear? What is it? Is it really difficult to see what I'm seeing? Is that what it is? Okay, this is what it is. This patient has, number one, elongated coronoids bilaterally. This is the coronoid, right? If you follow the coronoid anatomy, it's here, it's ending here. This is far ahead and superior to the level of the condyle, both the aspects. Okay? Plus, if you see the pterygoid plates, this is the pterygoid hamulus, lateral pterygoid plate, maxillary tuberosity, hamulus, lateral pterygoid plate. And then if you see the mandibular foramen here, there's a big radiolucency on either aspects, bilaterally. This should give you an idea that there is some amount of variation in the mandibular nerve itself, right? Okay, 26-year-old female, pain in the lower border, right side. Am I taking a toll on you guys or what? You guys are so silent. I know it's Post-Lund syndrome, but I think you guys should be awake, right? That's the reason why I walked you through to the normal anatomy in the beginning. The part one was the normal anatomy. We're talking about the variations now. Okay, this is the patient. This patient had, okay, this is the initial radiograph. Look everywhere. There's a pointy thing here. Both sides. You have two spikes. You see it or no? You see the pointy spikes? What region is this? Clinically, zygoma, yes. This patient had a zygomatic tubercle bilaterally. Because of with constant reddening of the face, we had to surgically excise it. Reddening, and itching, and also tingling sensation. Okay, 37-year-old male, again. Look beyond what you see. Okay, fantastic. Okay, what else? Come. Okay, I'll make the suspense. See, again, if you try to interpret too much, you begin to see what is not there. Okay, because you're seeing too much of variations, you're searching for in the wrong places. Actually, the variation is here. When you follow the mandibular canal, it is not straight. You see a curve here, you see a small canal coming out here. This is a retromolar canal. Again, this attributes to the repeated failure of anesthesias. When a patient comes to you and then the anesthesia is not working, no matter what you guys are doing, this is one of the reasons. The patient is having an additional branch of the mandibular nerve, which is coming out either from the ramus or from the other aspects or in the lingual aspect. You always